In this video, we're going to talk about some of the consequences or potential consequences of sodium bicarbonate administration in DKA. Currently, there is not a lot of evidence to support the administration of sodium bicarbonate in acute DKA, and this is for a couple of reasons. One is that the administration of sodium bicarbonate in the presence of acute DKA is typically associated with actually prolonged hospital stays or prolonged hospitalization. So we're not seeing the positive effects that we would typically expect when it's being administered. So no significant positive impact with prolonged hospitalization on top of that. And there is actually some evidence to support the fact that these patients may have poorer outcomes as a result. So the rapid administration of sodium bicarbonate in acute DKA is typically not supported or promoted. That being said, there are some institutions or protocols that support the administration of bicarbonate in acute DKA when the pH levels are below 7 or 6.9. That being said, there is not a lot of evidence to support that these things do not happen. Typically, the evidence is supporting that these things, prolonged hospitalization, poorer outcomes, will continue to happen even at pHs of less than 7.0. So, although the current practice is to suggest the administration of sodium bicarbonate at these lower pHs, the evidence supports that these patients will typically still have poor outcomes and more prolonged hospitalization. So, we can talk about a few reasons for that. So, there are a few reasons or theoretical reasons why we may see this in patients who have acute DKA. One is that the administration of bicarbonate and the immediate correction of the acidosis can actually lead to an increase in ketoacidosis for these patients. So we actually see an increase in ketoacid production and prolonged ability to correct ketoacidosis. One of the other pieces associated with bicarbonate administration is that it can actually worsen cerebral edema. So the patient may actually see an increase in cerebral edema, which we know, especially in children, is a consequence to diabetic ketoacidosis and something that we need to be mindful of. And then finally, one of the other challenges associated with bicarbonate administration is the patient may experience more severe hypokalemia, which is often a cause of cardiac arrest in these patients and something that's trying to be actively managed in acute DKA. So it can actually prolong management of some of the overall consequences. So let's take a look at these pieces individually. So in terms of the increase in ketoacidosis, what we have to think about is, well, how do ketoacids how are they being produced in the first place? And we have to remember that this is the result of lipolysis. So in the type 1 diabetic or the patient experiencing diabetic ketoacidosis, we know there is an absolute reduction of insulin, which is leading to lipolysis. And not only is lipolysis being promoted, but this patient has the inability to essentially inhibit against lipolysis. We see an increase in lipolysis. The whole benefit or the process behind lipolysis is designed to produce free fatty acids. So we're going to see the production of free fatty acids, and this is supposed to help with metabolism to acetyl-CoA, which will help with production of glucose or gluconeogenesis. So free fatty acids will be metabolized into acetyl-CoA, which will help with gluconeogenesis. Now we know that the other problem is that when acetyl-CoA is metabolized in the liver, one of the other byproducts of this can be our beta-hydroxybutyrate and acetone, or keto acids. So the patient will be producing keto acids as a result, and we start to see an increase in these keto acids in the liver. As blood supply makes its way through the liver, we can see those keto acids then being moved into the blood supply and creating the ketoacidosis that we know is occurring in diabetic ketoacidosis. Now, what we have to remember is that there are rate-limiting steps here. The production of keto acids and then the movement of those keto acids into the blood supply are concentration dependent. So the ability to metabolize acetyl-CoA into acetone and into beta-hydroxybutyrate is going to be dependent on how much acetone and beta-hydroxybutyrate I have in the cells of my liver. When I have an increase in keto acids, there is a proportional decrease in rate of production of keto acids. It's like an assembly line. When I have too much product, the assembly line will slow, or there will be a reduction in production speed in order to allow some of the product to exit. So one of the challenges that occurs when a patient is given bicarbonate and we see rapid correction of the acidosis. So we use green here to indicate our bicarbonate. So if we see rapid correction of the acidosis, what happens is we start to decrease concentration, which can further promote an increase in production. So we can actually increase production speed for these patients by decreasing the concentration gradient in the liver and the blood, and actually promoting faster or an increased production of keto acids from the metabolism of acetyl-CoA. So we need to start trying to correct the problem at this level. So at the level of lipolysis and the release of counter-regulatory hormones in the absence of insulin, before we start correcting the problem here, because if we haven't corrected the downstream problem by reducing the concentration, we're just going to increase production because we haven't stopped this process from occurring. So one of the consequences is we can actually see an increase in ketoacidosis because rapid correction can lead to increased production. The rapid correction of acidosis can actually lead to increased production of ketoacids. One of the other consequences we can see for this patient is an increase in cerebral edema. So we know cerebral edema is a risk for these patients, especially when we're looking at correction. So when we look at the cells of the brain, one of the challenges is that as the blood becomes hypertonic, we know that the cerebral cells are going to increase production of what's called an idiogenic osmole, or essentially an osmole that is designed to try and increase the hypertonicity or the tonicity of the cerebral cells to balance out the fluid shifting that's occurring, because we know there's lots of glucose in the blood, so fluid is shifting out of these cells. So the osmole is designed to attempt to reverse or manage that gradient a little bit better. So one of the reasons why fluid administration typically has to be careful in someone who has DKA, because if we overcorrect, we can lead to cerebral edema. If we're managing this patient and attempting to decrease the potential for cerebral edema, we don't necessarily want to give something that has the potential to increase cerebral edema. And the way in which bicarbonate increases cerebral edema is through the bicarbonate buffer system. So if we think about CO2 plus H2O, we have our carbonic acid, and then hydrogen ions and bicarbonate. When someone is rapidly correcting the acidosis or giving sodium bicarbonate and dramatically increasing HCO3 levels, what will happen is we're going to see a leftward shift. So we're going to see the bicarbonate doing its job and acting as a buffer and actually shifting this equation to the left and increasing CO2 and H2O production. Now, patients have to have the ability to exhale this CO2 in order for bicarbonate to be effective. And one of the problems that exists in patients who have diabetic ketoacidosis is they're often experiencing poor perfusion or decreased blood pressure as the result of the volume loss that they have experienced through osmotic diuresis. They have poor perfusion, which often leads to a decreased pulmonary perfusion or the ability to get CO2 to the lungs. So if this patient has a decrease in pulmonary perfusion or the ability to get CO2 to the lungs, that means that the CO2 is going to maintain or it's going to increase in their blood. So because of this poor perfusion and the ability to offload CO2 to the lungs, when you give bicarbonate and you cause this left shift to the bicarbonate buffer system, the consequence to that is often an increase in serum CO2. So we see an increase in serum CO2 for these patients, or their CO2 levels go up, and CO2 can actively cross the blood-brain barrier, and it acts as a vasodilator. So what happens for patients, you get this increase in serum CO2, which then leads to, and I'll use this dotted line to indicate the vasculature, we get vasodilation in the brain, an increase in permeability, which can lead to worsening cerebral edema. So one of the challenges of bicarbonate administration is it often increases serum CO2 levels, which can further lead to an increase in cerebral edema. So we see an increase in serum CO2, which can lead to an increase in cerebral edema. This is especially true, again, in patients who are in DKA who are volume depleted because they don't have the circulatory capacity to support that increase in CO2 to shift it towards the lungs and blow off all that CO2. So that's one thing to be mindful of, is we actually see worsening cerebral edema. And finally, we can see hypokalemia. So we said that one of the problems when a patient is in an acidotic state is they will exchange potassium ions for hydrogen ions. So we know that potassium typically lives in the intracellular environment. When a patient becomes acidotic, one of the things that you will see is potassium ions will shift out into the blood, while hydrogen ions will shift out of the blood and into the vasculature. So we'll see the trading of of potassium ions for hydrogen ions. So hydrogen is moving in while potassium is moving in. The problem in the patient who's experiencing DKA is that they often pee out all of this potassium. So they're depleting their body of potassium levels. So we see a reduction in potassium. So not only are they shifting that potassium out into their blood supply, they're depleting their intracellular potassium because it's being lost to the urine, which promotes a hypokalemia. Now, what happens when we rapidly correct acidosis, or we start to see the patient becoming less acidotic, is the opposite. So if we look at the effects of bicarb, what bicarb is actually going to do is lead to a rapid increase in pH, or we see a correction of pH, and the opposite can start to occur. So if pH starts to go up, the body will attempt to mitigate this or balance it out by leading to hydrogen ions moving back out into the blood supply and trading that for potassium. Well, what will happen as a result is we start to see potassium ions moving into the cell and moving out of the blood supply. So a patient who is already hypokalemic is now storing more potassium intracellularly and leading to a further reduction in serum potassium levels. So a rapid correction, or basically the creation of an increase in pH, can actually lead to the reversal of the shifting. So H plus will shift out of cells, and we have K plus efflux into the cell, or influx into the cell, which will reduce our blood levels of potassium, and the patient can be at risk of hypokalemia and arrhythmia, which is one of the things that, again, are usually typically going to be corrected in the patient with acute DKA. A couple of the key points here is that the administration of DKA often leads to prolonged hospitalization, and there's some evidence to suggest poor outcomes for patients. And again, this exists even at lower pHs. So there's no evidence to support the administration of bicarbonate at lower pHs. This is a theoretical process that's driving the provision of bicarbonate to these patients. But when we look at some of the potential negative outcomes, this can lead to actually an increase in ketoacidosis, an impairment in trying to fix the problem of lipolysis, and ketoacidosis can lead to further cerebral edema. So we're already at risk of cerebral edema when we are providing fluid to these patients or attempting to manage hypovolemia. The provision of bicarb can actually worsen that cerebral edema. And then when trying to mitigate potassium levels, so attempting to determine total body levels of potassium and correct potassium levels, the administration of bicarb can lead to an alkalotic state in the blood, which will shift hydrogen ions out of the cell, potassium ions into the cell, actually furthering a hypokalemia.